metabolic dysfunction associated steatotic liver disease, pathogenesis, clusters, and recent treatment advancements. A presentation from Cardiapcon First Society of India in Cardiodiabetes and Renal Disease. I am Dr. Ashutosh Mishra, Secretary Cardiapcon. Welcome to our weekly podcast. Introduction. Welcome to this comprehensive overview of metabolic dysfunction associated steatotic liver disease, or MASLD. Today we'll explore the heterogeneity of this condition, its various pathways, emerging clusters, and the latest treatment strategies. MASLD, formerly known as non-alcoholic fatty liver disease, NAFLD, is a growing global health concern, closely linked to obesity, type 2 diabetes, and cardiovascular disease. Pathogenesis of MASLD. Shared pathomechanisms MASLD typically develops due to excessive intake of glucose and fructose, increased fatty acid production via hepatic de novo lipogenesis, higher intake of saturated fatty acids. These factors lead to subclinical inflammation in adipose tissue and liver, insulin resistance in adipose tissue, liver, and skeletal muscle, hyperinsulinemia and hyperglycemia, hepatic mitochondrial dysfunction, increased oxidative stress, activation of fibrogenic response in hepatic stellate cells. Genetic factors. Several genetic variants contribute to MASLD pathophysiology. PNPLA3 regulates mobilization of triglycerides from lipid droplets. TM6SF2 involved in assembly and secretion of VLDLs. MB087 affects hepatic phosphatidylinosytol acyl chain remodeling. GCKR influences de novo lipogenesis. HSD-senescent-B-treen. Mechanism still unknown. Importantly, adiposity amplifies the effects of these genetic risk alleles. Major pathways in MASLD with dominant hepatic genetic component. Increased risk of hepatic steatosis, inflammation, fibrosis, and hepatocellular carcinoma. Often no increased risk of cardiovascular disease associated with low blood triglycerides and LDL cholesterol 2. MASLD with dominant metabolic component related to hepatic de novo lipogenesis, characterized by insulin resistance, hyperglycemia, and hyperinsulinemia, higher rates of de novo fatty acid synthesis, linked to higher risk of myocardial infarction and coronary artery disease 3. MASLD with dominant metabolic component related to adipose tissue dysfunction. Often seen in lean MASLD patients, characterized by dysregulated lipolysis in adipose tissue, associated with higher risk of all-cause mortality. Clusters in MASLD. Recent studies have identified distinct clusters of MASLD patients. 1. Liver-specific cluster. Strong genetic component. Alligator PNPLA3 variants. Higher risk of liver disease progression. Lower risk of cardiovascular disease 2. Cardiometabolic cluster. Dominated by metabolic factors. Higher risk of cardiovascular disease and type 2 diabetes, characterized by insulin resistance and dyslipidemia. Adipose tissue dysfunction cluster. Often seen in lean MASLD patients, characterized by dysregulated lipolysis, higher risk of all-cause mortality. Age-related cluster, more common in older individuals, may involve unique age-related factors like oxidative stress. 5. Mixed hyperlipidemia cluster, characterized by severe mixed hyperlipidemia, distinct lipid metabolism abnormalities. 6. Diabetic subtype, high prevalence in type 2 diabetes patients, may involve specific diabetes-related mechanisms. So genetic subtype, driven primarily by genetic factors, independent of metabolic health, may have a different prognosis and treatment response. Recent advancements in MASLD treatment, lifestyle interventions, weight loss goals, 5% or more, to reduce liver lipid content, 7 to 10% to improve liver inflammation, 10% or more to improve fibrosis. For lean MASLD, 3 to 5% weight loss, recommended bariatric surgery, effective for patients with substantial obesity and comorbidities. Significant improvements in MASH resolution and fibrosis reduction. Pharmacological treatments, SGLT2 inhibitors, reduce glucose burden and promote weight loss. Potential direct effects on inflammation and ketogenesis. Example, dapagliflozin showed promising results in a Japanese trial. 2. GLP-1 receptor agonists, semaglutide and liraglutide, show promising results in MASH resolution. Significant weight loss and metabolic improvements. Semaglutide demonstrated MASH resolution and fibrosis improvement in phase 3 trials. 3. GLP-1 and GIP receptor co-agonists. Tirzepatide shows superior effects on weight loss and glycemic control, potential to reduce ectopic lipid deposition. Demonstrated significant MASH resolution in phase 2 trial. 4. GLP-1 and glucagon receptor co-agonists. Survodutide demonstrates improvements in MASH and fibrosis. Pemvidutide also being studied for MASH treatment. 5. GLP-1, GIP, and glucagon triple agonists. Retatrutide and efosapegrutide show promising early results. Significant reduction in liver fat content observed. FGF21 analogs. Pegozafermin and efruxifermin show promising results in MASH resolution. No significant changes in body weight or HbA1c. Multiple other FGF21 analogs in early development stages. 7. Thyroid hormone receptor P agonists. RAS made Tyrone approved for non-cirrhotic NASH with moderate to advanced liver fibrosis. Improves lipid metabolism without affecting body weight. First drug to receive conditional FDA approval for treating fibrotic MASH. 8. PPAR agonist, pioglitazone. Effective for MASH resolution, but associated with weight gain. Lanifibranor, pan-PPAR agonist, shows improvements in MASH and fibrosis. Other PPAR agonists, example, saroglitazar from India, in various stages of development. Personalized treatment approaches. Based on MASLD subtypes. 1. Strong hepatic genetic component. Focus on liver-directed therapies. Monitor for hepatocellular carcinoma risk 2. Strong metabolic component. De novo lipogenesis. Emphasize diet modification and exercise. Consider incretin receptor agonists or bariatric surgery. Aggressive management of cardiometabolic risk factors. Adipose tissue dysfunction, lean MASLD. TR agonists, multi-incretin hormone receptor agonists or FGF21 agonists may be preferred. Focus on improving adipose tissue storage capacity and ectopic lipid oxidation power. Severe type 2 diabetes associated MASLD. Comprehensive approach, including SGLT2 inhibitors and incretin receptor agonists. Tailor treatment to specific diabetes phenotypes. Conclusion: the heterogeneity of MASLD necessitates a personalized approach to treatment. As our understanding of disease clusters and pathophysiology grows, we can expect more targeted and effective therapies. Ongoing research continues to uncover promising treatments, with some, like resmetirom, already reaching clinical practice. The future of MASLD management lies in combining lifestyle interventions with tailored pharmacological approaches based on individual patient characteristics and disease subtypes. Thank you for your attention to this comprehensive overview of MASLD pathogenesis, clusters, and treatment advancements. This is Dr. Ashutosh Mishra signing out. Take care. Bye bye and namaskar.